Recording in progress.
Welcome to Wildcard Wednesday. It is February 18th, 2026. So first, I'd like to apologize for starting Wildcard Wednesday back on January 21st, saying it would be a weekly feature, and then I did not get around to going through any cases over the past several weeks. My schedule has just been so crazy with so much going on, and finally, I'm actually to a point of being caught up. I feel like I've been working from behind for 3 months. So I finally can see the light at the end of the tunnel, and I do hope to post at least one case every week for Wildcard Wednesday on the YouTube channel. So because I haven't done cases in a few weeks, I actually decided to look at two cases for today. So I'm going to go ahead and jump into the first one. Actually, before I do that, I want to remind you, if you have a case that you are finding challenging to code, you can submit your case for Wildcard Wednesday, and you can do so by going to radarx.com and then clicking the Contact Us button, and then submitting your de-identified report through our contact form. And then each week I'll pick one or two cases to walk through. Okay, so let's get into the first case for this week. So first thing I'm going to do is just read through the report. This is a very short report that was given to me. And the reason why I want to read through the report is I want to point out issues with the documentation before we actually get into the coding, because this one is problematic from a coding perspective to get the accurate codes based on the documentation. So this particular patient was admitted with anemia and bilateral lower extremity weakness. Evaluation revealed critical stenosis of the distal abdominal aorta and proximal common iliac arteries. The patient was taken to the endovascular suite for further evaluation and treatment. So it appears that the stenosis is identified already on some other prior imaging, and now the patient is coming for further evaluation and treatment. So it appears that there is an intention to actually treat. So at this point, based on the history, as far as the imaging is concerned, I'm not feeling confident that it's actually going to be diagnostic in nature. But anyway, let's continue for right now. So we have our preoperative and postoperative diagnosis being the same: bilateral lower extremity ischemia. For the procedure summary, we see an abdominal aortogram with bilateral lower extremity runoff, bilateral femoral arterial access, angioplasty and stenting of the distal abdominal aorta, and bilateral common iliac arteries. And then we see in the findings, critical stenosis of the distal abdominal aorta successfully treated with angioplasty and stenting. So based on the findings, it looks like we're going to be coding a stent placement in the aorta. When we get down in the procedure note, you'll see that there are some questions that are going to be raised based on the documentation. So the procedure note: bilateral common femoral arteries were accessed using ultrasound guidance and micropuncture technique. We do not have documentation to support 76937, the ultrasound guided vascular access. We need all four criteria as noted in the code description in order to report that. That is not here. We see that the guide wire was advanced into the distal abdominal aorta. And then in that second paragraph, contrast injection confirmed critical stenosis of the distal abdominal aorta just above the iliac bifurcation. So we see that it's saying it's confirming critical stenosis. We knew that from the history. Again, I'm not seeing anything here that's telling me that the imaging is diagnostic. The other thing that I want to note here is that the contrast injection was performed, and the only findings that are associated with that is that critical stenosis in the distal abdominal aorta. Then it goes on to say the lesion was crossed with guide wires and sequential balloon angioplasty was performed. A balloon expandable bare metal stent was deployed in the distal abdominal aorta and post dilated. Okay, so we see that there was a stent deployed in the aorta for that stenosis that is present. Then we go down to the next paragraph where it says persistent irregularity in the proximal common iliac arteries prompted placement of bilateral kissing stents extending into the distal aorta. These were simultaneously inflated and post-dilated to achieve adequate luminal expansion. Then we see completion angiography was performed, and then that's it. This report basically just mentions that now we have a patent distal abdominal aorta, patent vessels, and then the procedure ended. So with this report, you can probably tell, as I mentioned before I started reading through it, is that we really have some deficiencies here in the report. So first of all, it does not appear to me that we have enough information to determine whether or not we should be coding this imaging as diagnostic angiography. If we go back to our CPT criteria, the decision to intervene has to be based on the imaging in order for it to be diagnostic. Obviously, there's a lot more to that criteria there in what CPT gives us, but that's really what it mostly is going to hinge on. And so, because it appears that we have a diagnosis that was made prior and the patient is coming for an intervention, we're going to assume that that is not diagnostic and we're not going to code the imaging. Now, even if we had the correct history, and let's say there was no prior, exam that had diagnosed the patient, let's say it said angiogram with possible intervention. Even when we come into this report and we look at it, the only findings we see documented are critical stenosis of the distal abdominal aorta. We don't see any other diagnostic findings for anything. So let's say this imaging is diagnostic. What do we do? Do we have what we need to code? We do not. This is the issue that we have. The report, when we go to the procedure here, and the procedure says abdominal aortogram with bilateral lower extremity runoff, that makes you think either 75630 or 75625 and 75716. To assign a 75625 or a 75630, there have to be findings for the abdominal aorta and the origins of the renal arteries, celiac, IMA, and SMA. In this report, we see that the distal abdominal aorta is mentioned. So when only the distal abdominal aorta is mentioned, that means we cannot get a 75625. We cannot get a 75630 because there was no complete evaluation of the abdominal aorta. This is in the distal abdominal aorta near the bifurcation. So based on our procedure summary, we've now eliminated our abdominal aortogram code, the 75625. I'm sorry, I had to check something real quick. I'm like, did I hit record? Yes, I did hit record. I wanted to make sure that I hit record. Okay, I thought maybe I had forgotten. So anyway, when we're looking at this, now the only possible code that we would have would be a 75716 because that actually is just mentioning the distal abdominal aorta. But we don't see any findings for the extremities, like at all. The only thing that we see about the extremities is that it says persistent irregularity in the proximal common iliac arteries, prompted placement of bilateral kissing stents extending into the distal aorta. We don't know specifically what was going on, just a persistent irregularity. What is that? That's like the question. What is that there? So going back now to deciding, okay, we don't have enough to assign an imaging code. Even if we wanted to assign a 75716, we don't have enough findings in here to assign a 75716. So regardless of whether we had, something telling us, angiogram with possible intervention, there's nothing here to code. The findings actually do not support the imaging. So we wouldn't assign anything there. Okay, so now we've established we're not going to assign our imaging codes. So now what do we do with our intervention? Now, again, here's where we're lacking some information in order to code our intervention. So we see that this stent was deployed in the distal abdominal aorta. Then we see in the proximal common iliac arteries, we have placement of bilateral kissing stents extending into the distal aorta. So this is the question is, do we have separate and distinct lesions here, or do we not? Or is it a continuous lesion? We don't know. So when I look at this report, there are different possibilities here to code it. If we have a single lesion, a separate lesion in the abdominal aorta itself, that would be a 37236 for the stent placement in the aorta. But when we're talking about placing a stent into the common iliac arteries, then we're looking at our lower extremity revascularization codes, and that would be 37254 for a straightforward lesion. That's what we would go with because we have limited documentation in this report. And so the question is, do we have 37254 on the right, 37254 on the left, and 37236 in the aorta? If we're talking separate and distinct, that aortic lesion, or if it's not, should this really be a 37254 times 2 if the stenosis in the distal abdominal aorta was going into the iliacs? So this really leaves a lot of open-ended questions for me. So I would actually go back to the physician and I would actually ask for more detail. I would ask for more detail about the imaging. I would ask for more detail about exactly what was treated. Because again, here, what is this persistent irregularity that we have there to place those stents for? So I don't really know. So as far as having a final answer to this case that was submitted, I do not have a final answer because to me, it does not have enough information in order to actually be coded. Now, if we go back up to the brief history, it does say critical stenosis of the distal abdominal aorta and proximal common iliac arteries. So even if we go back and we use that piece of information combined with the procedure, again, the question is, do we have separate and distinct lesions that are being treated? Because it's possible for that stenosis in the distal abdominal aorta to actually be connected to that stenosis that's in the common iliac artery. So I don't know here how many codes we have and what codes we have because we don't have enough documentation. So the common iliacs would be 37254, the aorta would be 37236, but we would need to know whether or not we have separate and distinct lesions. So that's my analysis of that case. So unfortunately, I don't have enough information to assign final codes to this case. I would send it back to the physician and query about the information that is missing from the report in order to make the appropriate code selection. So now let's take a look at case number 2. This is for a transhepatic embolization of the left gastric vein. Of the left and the posterior gastric vein. That's what it says in the history. Okay, the examination. So I think we're missing a word there in the history on this report. So anyway, history indication, it's a patient with underlying cirrhosis with bleeding gastroesophageal varices. It does mention there's no prior CTA, only a CT abdomen and pelvis without contrast. So it seems that this report is attempting to tell us, yes, you should be coding the imaging as diagnostic angiography. Now, I'm not completely 100% thrilled with that documentation. I would want to see a little bit more detail letting us know that the imaging is diagnostic. However, because this is a situation where they're doing embolization with bleeding, they typically have to go in and do the diagnostic imaging in order to determine the source of the bleed, even if there is an active bleed. So in this case, I'm going to say, okay, let's go ahead and code the diagnostic imaging. Although if I was auditing this, I would send it back with a documentation recommendation on it. So we see that we have sedation documented 120 minutes. So that would be our 99152 and then our 99153 times 7. When we get into the actual report, we see in the second paragraph under technique, we have under fluoroscopic guidance, the tract to the right lobe of the liver was anesthetized. 22 gauge needle access went right into the right posterior portal vein. And so when you have the direct access into that portal vein, that is going to be a 36481 for that catheterization. Then from there, when we go down to the next paragraph, we see that a catheter went into the splenic vein and a venogram was performed. Then from there, the posterior gastric vein was catheterized and a venogram was performed. Then we have an embolization of the posterior gastric. Then in the paragraph below that, we have the left gastric vein being catheterized and an embolization is performed there. So are we going to code our imaging and what are we going to code? I'm going to say, yes, we're going to code our imaging on this case. Again, I would send it back with a documentation recommendation. But why are we going to assign our imaging codes? What are we looking for? We're looking for findings for all of the angiograms that were performed. So when we come down to the findings section, we see initial portal venogram, we see findings for that. Initial splenic venogram, we see findings for that. We also see findings for the posterior gastric venogram, and then we also see findings for the left gastric venogram. So we know that we're going to code for all of that imaging that occurred. So we know we're going to code for our imaging, our embolization, our clinical indication. If we go back up to the top, it was for the bleeding varices. So that's going to end up being a 37244 for the bleeding varices. So the embolization code, very straightforward. So now let's talk through our catheterization codes and our imaging codes. So again, that initial catheterization, going into the portal vein, that's the 36481. But then the catheter goes into the splenic vein, which is a first order for that venogram. So that venogram, so let me back up for a second. First, the portal vein, when that was catheterized, it doesn't say it here in this second paragraph, but in the findings, it says that an initial portal venogram was performed. So we see that. So even though that information is missing from that third paragraph, because we see it in the findings, we're going to go ahead and code for the portal venogram. That is going to be our initial imaging code, and that's going to be the 75887. That is without the hemodynamics. So then the catheter goes into that splenic vein, venogram is performed. So what code are we going to assign for that splenic venogram? We're going to use code 75774. You may remember that January 1st, 2025, CPT changed the coding rules where 75774 can now also be used for venous angiography. It is not just used for arterial procedures. So rather than using the unlisted, which we used to, the 76496, you can actually use the 75774. Why are we using the 75774? We had a base code of 75887 in the portal vein, and now we're going into the branches off of the portal vein. So now we're going to use that additional imaging code, the 75774. So the splenic vein was catheterized. That's a 36011 with that 75774, but then the catheter goes into the posterior gastric vein, which is off of the splenic vein. So that means that the splenic vein catheterization code goes away. That gets eliminated because the posterior gastric vein is a second order vein. So that makes that a 36012. And then the venogram of the posterior gastric vein is also a 75774. And then we've already assigned our embolization code 37244. Now we go down to the last paragraph here before the findings, where the left gastric vein was catheterized and an angiogram was performed. So the left gastric vein is a first order vessel. So that's going to be coded with 36011. And then again, the imaging of that vessel is going to be 75774. So how this ends up coding, our final codes come out as 36012 for the posterior gastric vein. The splenic catheterization is bundled. We have 36011 for our left gastric vein catheterization. We have 36481 for the portal vein catheterization. We have 37244 for our embolization code. And then we have for our imaging codes 75887 for the portal venogram without hemodynamics. And then we have 75774 for the splenic vein, the posterior gastric vein, and the left gastric vein. So this report, it is very brief, it is very to the point, but it does have almost all the documentation that we need in order to code what we need to. Again, I would like to see a little bit more in that history, about whether or not the decision to intervene had already been made prior to the patient coming for this procedure. I feel that this is lacking a little bit there. But again, because it is a situation where they're being referred for bleeding, in almost all cases when it's a bleed, they do the diagnostic angiography to determine the source of the bleed. If there even is an active bleed, sometimes there may not be an active bleed when they are actually, doing the procedure. And even if there isn't an active bleed, if they go ahead and move forward with the procedure, you would still code it with the 37244 in that particular case, because that diagnosis of bleeding had already been established. So hopefully you learned a little something from looking at these two cases. And whoever submitted case number 1, I don't remember off the top of my head. I would recommend that you go back to your physician and you ask for more detail in order to code that report appropriately. Anyway, thank you for tuning in, and I'll be back next week with some more cases for Wildcard Wednesday. Thank you for tuning in.